Thank you. Okay, I have no disclosures. Really, I just have two main objectives with this talk this afternoon. The first is to go over exactly what crisis resource management is, what it means to us within OB anesthesia, and then to discuss the benefits of this on training and outcomes. Okay. So first, the meaning of crisis. Obviously, we experience this all the time. It's really that sudden change in course of a patient's disease, when that severe preeclamptic goes into flash pulmonary edema, an unstable condition where you need to act quickly, that abruption, that uterine rupture, these critical events. As the anesthesiologists, we have this mandate in our mind that we need to ensure safe resolution of the crisis in this perioperative arena. And we need to do it within the team that's around us, the obstetricians, the labor nurses, and other personnel. Okay. Why is this so difficult? There's a lot of challenges in the perioperative environment. Things are very dynamic. People are bleeding. People are seizing. They're complex. Patients have a lot of comorbidities. Things are very uncertain. You don't always know what's going on exactly that's leading to the condition that you're currently in. Our job is inherently risky. We have people's lives at stake. There's a lot of time pressure. You know that if you don't accomplish certain goals in a timely manner, things are going to get worse. You're often getting incomplete feedback. So when I was looking at all these ideas about why it is so difficult for us, I was thinking about a case that I had done not that long ago, where it started as just a standard cesarean section. We were going along, and we were getting to the point where they're just beginning to close the uterus. The child had come out, everything was fine, and the pressure's starting to go down. The patient's getting more and more tachycardic. To me, the signs look like there should be some bleeding, so I look on the field, see if the uterus has tone, ask the surgeons about the bleeding. They're saying, everything looks great to us. Things are getting worse, more and more tachycardic. We put in an A-line. I tell them there has to be bleeding somewhere. Something has to be wrong. They're looking, taking drapes down. We see a little bit of blood. They decide they're not going to close. They'll re-explore, calling in additional teams to try to find it out based on my feedback that I'm giving them. Okay. It turns out we end up putting in a central line. Tons of blood is being lost. What has happened is that during the hysterotomy, the wound extends into the broad ligament, takes out the uterine artery, that goes back retroperitoneal, and just by chance, there's a connection between the retroperitoneal space and the vagina. Okay? So we can't see the liters of blood that we're losing. We're getting incomplete feedback. We go through a full code. We end up saving the patient's life after an enormous amount of time and effort and individual involves. But every one of those items on this slide was part of that case. And I would bet it's probably part of every case that you have that's a crisis that you encounter. Okay. So the model that we use, crisis resource management, was originally obtained from commercial aviation. Okay? Dr. Siegel yesterday talked to you a little bit about it in his talk on procedures. It was originally adopted by United Airlines in 1981. It's been used by a lot of other industries, the military, firefighters, nuclear power, the space agency, right? It's really based on two ideas, technical skills and non-technical skills. We're actually pretty good at our technical skills. We do these every day. So just like the aviation industry, they fly planes every day, their cabin crew takes care of passengers, where are the exit doors, are you wearing your seat belts, and so on. We know how to put in A-lines, intubate individuals, put in central lines, transfuse blood. The technical skills really aren't as big an issue, I think, as the behavioral skills, okay? And so their model focused on non-technical skills in addition. Resource management, leadership, communication to the individuals around you, awareness of the situation, and coming up with appropriate judgment based on that. Okay. So In about 1990, Dr. Gaba at Stanford VA took what he had learned as a pilot from crew resource management and changed it to crisis resource management. Okay? And he brought it into anesthesia. And he modified what the airline industry had done into the medical arena. And again, really focusing on the behavioral skills, they're almost identical, right? Leadership, communication, assessment of the situation, and how are you going to manage your resources. Okay. What crisis resource management does is it really provides you a framework for you to speak a common language with the other disciplines around you, nursing, obstetricians, the neonatologists. It gets you talking about leadership and improving these behavioral skills, and that's really what this is all about. Okay? So again, most days you're flying along, everything looks great. As I say, 99% of the time when I do my job, I feel like they're paying me way too much. And then 1% of the time, both my engines are out, I'm landing the plane on the Hudson, I'm worried about all the passengers on board. Okay. So what are the principles? The principles of crisis resource management. You want to know your environment around you. Who are you working with? What are their names? Who are the obstetricians? Who are the labor nurses? Who is the administrative staff at the phone? Who are the people in the blood bank? Okay. You need to be able to communicate effectively. Closed loop, articulate communication. Who's taking the leadership role? You only want one leader at a time, but you want that leader to know everybody, to be decisive, and have a good understanding of what's going on. You want them to be able to share a clear goal and objective for the situation. You want to be able to distribute the workload for that crisis fairly evenly. You have some individuals getting information. You have some individuals treating the patient. Okay? You want to stop periodically and review for more ideas. You want to call for help early. It's been shown over and over again that in these times of medical crisis, things only get worse with time, and eventually they go exponentially worse. Okay? You want to know all the resources around you so that you can use them effectively. Okay. So within OB anesthesia, within the obstetric perioperative environment, you really want to focus on multidisciplinary training. Okay? Within anesthesia for us, that's faculty and staff. If you're at a teaching institution, you'd want to include residents or medical students. Within obstetrics, you've got obstetricians, midwives, family practice individuals at some institutions delivering. They need to be included in the training. Labor nurses, neonatologists. And for some of the simulations, you want to include additional personnel, people in the blood bank, your support staff, your PCAs, your OR techs. So everybody's on board. There's really two ways to do this. Okay? There's simulation centers and there's in situ training. So in the simulation center, there's some advantages. It's very tightly controlled. It's a very standardized experience, right? You have skilled facilitators and technicians, people who've trained in educating in crisis resource management, often very high-tech AV equipment for providing feedback. There can be downsides though, right? There's unfamiliar equipment often used. It's not what you use in your daily practice, and you can get thrown by, well, it was just I didn't know how to work that piece of equipment, right? Lack of all the colleagues you're working with. Normally, you're taking point people from certain disciplines and bringing them to these simulation centers. There's travel, there can be cost involved. There's scheduling with the simulation center. Okay? In situ, it's more familiar to you. It is the work environment you are in. There's multidisciplinary learning, and a lot of the focus is often on system problems and workflow. What's not working for us in these situations? How can it be improved? What's a response time for a crash section, for getting them in the OR, prep, drape, cut? Okay? In situ has its own problems. There can be scheduling difficulties because everyone's working there. It's a clinical location, right? There's logistic difficulties with that. What are we going to do in order to have the simulation go on, and what if this clinical case comes in? How can we use the OR? So there can be logistical issues. You definitely have to have leadership on board. You need point people in every discipline, and you need a plan for how you're going to do that. So at UCSF, as an example, we take residents who currently aren't scheduled for clinical duties. We choose times that nurses are either coming on an hour before their shift or staying an hour after their shift, right? We work together with the obstetricians also. They have residents and faculty who are not currently scheduled for duties. So there's compensation issues for that if you're in private practice, because people are coming in and devoting their own time. So again, this has to really come from within, how important this is and what a difference it can make. I think most places that do in situ have sent a core group of individuals to a simulation center or to a formalized training course so that they can learn the language and impart it to the other people who will be taking part in these simulations at their institution. Okay. So what are your options? So you already heard about team steps yesterday. There's other options. You have ACRM down at Stanford. You have TOMS based out of Switzerland, but within the US. There's class-based options also. I'm not advocating one of these as being better than the other. Just know that there's these and many more. They're easy enough to find. Okay. What kind of drills and simulations would you do? Well, crash sections, seizure drills, procedure drills like shoulder dystocia, right? Hemorrhage protocols, things we're used to, total spinals, failed intubations, anaphylaxis, and so on. There's plenty of others too. Okay. One opportunity that presents itself with the in situ simulation was presented by Paul Preston from Kaiser back in 2011. Let's say you're moving into a new facility. For example, we have a new facility coming up in Mission Bay in a couple of years. A lot of things are still being developed. We're part of a lot of meetings, but sometimes I feel that anesthesia is not on all the meetings when the rooms are being developed in the workflow. I think it's really important to have these simulations take place before the patients arrive in these new locations. Where are the supplies located? Where's your airway cart? Where's the code cart? How are people being transported from one location to the other? What elevators are involved? Are there elevator keys? How's that going to work? How long does it take? How do you call for help? Do you have a standard paging system? Emergency blood, stat labs. These sound very basic. But I'm going to give you two true examples. So just yesterday I was talking to some individuals who told me they had one of their facilities where they worked at, that the initial plan had been the airway cart was going to be in a different building. And so if there was an airway emergency, it'd just be a 15-minute transit time to get the airway cart over there. Okay? They obviously weren't in favor of that, and it got rectified. Another hospital, the plan was they were going to take care of patients, but the blood bank closed at midnight. So if there was a massive hemorrhage, the blood would be taxi-cabbed from another building across town. Okay? When I was told that story, I was thinking about getting a cab in San Francisco out of downtown after 10 p.m. It's about an hour wait, even if you call around here. Okay? So it sounds like a very basic slide, but I'm telling you these things happen and it needs to be thought about, and you need to do the simulations. Okay. So what about the use of video equipment? Okay. There's a variety of studies on simulation. Some went over yesterday in the STEPS training. One that came to mind for me for this lecture was a recent one, 2006, looking at oral feedback versus video-assisted feedback. So a study out of Canada, smaller study with residents. They had 3 groups. They had a control group where they went through a simulation. They got no feedback. Another group got verbal feedback from skilled educators. And then a third group had the verbal feedback with the video feedback. Okay? And what they used was the ANT system that you see here in the table. So this is a variety of non-technical skills. Task management, working within the team, making decisions and awareness of the situation. All these elements are scored on a 0 to 4 scale, poor to excellent, and then you take your overall numerical score. So following the feedback or lack of feedback session, they went through a second simulation and they went to see how they improved. Well, as it turns out, obviously what you would expect, the people who got feedback did much better than the ones who didn't get any feedback. That's the 2 bars on the right, the middle and the dark bar on the right. The middle bar is the verbal feedback, and the black bar is the video-assisted feedback. Okay. So it turns out the video assisted didn't really do any better. It was basically the same across categories compared to the verbal feedback. Now the point of this is not that video feedback is beneficial. I think it is. But the point of this is don't wait. Don't wait to get a big video system. Don't wait to figure out how you're going to do that. Personal example, we've been working for 3 years to get a video camera in our main obstetric OR so that when we have crash sections, we can flip a switch and record it. We've gone through all the committees, we got all the legal permission, we're almost there, we just have a little bit of money now, okay? But it's taken 3 years. We didn't wait. We do simulations every month, okay? So that's the point of that, don't wait. All right. There's a ton of barriers. This takes a lot of effort, a lot of energy, a lot of money, and a lot of time. So you need support from the leadership in each one of the disciplines for this to happen, okay? You need to have an integrated vision, and once you get it going, you can't relent. You have to keep working on getting people used to doing this on a regular schedule. Okay, so how can you get started? Well, besides all the courses I posted there, besides talking to your colleagues, emailing us, what do we do, what scenarios can we use? There's the California Maternal Quality Care Collaborative. I have the privilege of sitting on their expert panel and would go around to different hospitals in the state and implement various hemorrhage protocols and simulation-based teaching. So there's their website. You go on the left-hand column where I've circled in red, OB Hemorrhage Toolkit. You click on that. That brings you to this page. You go to, in red, the best practices, and that brings you to a variety of simulations and drills that are free, that you can use, that are well thought out by experts in the field. Okay. So, where are we at with outcome? So, back in 2005 in JAMA, there was a article, where are we 5 years after the sort of seminal article, To Err is Human, okay? And we see different clinical practices that had been instituted, right? Physician computer order entry, pharmacists rounding with teams, rapid response teams in place, ventilator protocols. Well, the one that had shown to be of clinical benefit was the team training in labor and delivery. So at a hospital in Wales, they had a 50% reduction in adverse outcomes with preterm delivery just by doing team training. Okay? It's just one study. Okay? What else do we have? So systematic review published back in 2010 took all the articles through 2009 since the beginning of crisis resource management. Okay? They found a variety of articles that showed benefits in improved knowledge, skills, communication, with the simulation, with the training. Okay? The STEPS lecture yesterday talked to you a little bit about that. There's only one study that showed clinical outcome benefit. Okay? And this was a study where it was sort of a before and after retrospective study. They had about 8,000 births on this unit, and then the entire perioperative OB team went for training, and they had another 11,000 births on the unit after that intervention and after they took out the simulation. They improved their APGAR scores of those infants, where they went from a rate of 86 per 10,000 having a 5-minute APGAR of 6 or less, down to 45 per 10,000. So they cut it in half. They also cut their rates of hypoxic ischemic encephalopathy. They went from 27 per 10,000 down to 13 per 10,000. Okay? Now, unfortunately, over and over the review articles, I just went through it again before giving this lecture yesterday. Dr. Pratt out at Stanford, internationally known in this area, put out a nice review in 2012. Same thing. Lots of benefits to skills, communication, team performance. So far, we don't have that much with clinical outcome. Okay? But again, as you all know, we don't have it with pulse ox, we don't have it with our ECG, we don't have it with our blood pressure cuff, we really don't have it with fetal heart rate monitoring. Cochrane review on the pulse ox in 2009, still no evidence that pulse oximetry affects the outcome of anesthesia patients. The value of perioperative monitoring is questionable in relation to improved reliable outcomes, effectiveness, and efficiency. Now, there's none of us I don't think, that would not put a pulse ox on a patient before a case. The WHO, as you saw in the protocols yesterday from Dr. Siegel, pulse ox, right? Okay. So, an editorial in 2010 by Dr. Gaba I wanted to share with you. What is the impact of crisis resource management? His statement in this editorial is we really can't assess it yet. We are in our infancy. We are so far behind where the aviation industry is, and it took them years to get that up and running, and they still have barriers. So until we have a comprehensive, integrated strategy, right? It's intensive, it's continuous, it's repetitive. All the personnel undergo it. It's linked to programs of assessment and competence testing. Until all of this is done, we really won't know what the impact is. And so it shouldn't be disturbing to you that we don't have the clinical impact yet. We are just in our infancy of really getting this going. Okay. So his thought in the editorial, the status quo for education and training that we currently undergo has never been tested for efficacy and effectiveness. The rate of medical errors and near misses is testament to the fact that we can do much better. Every other industry that deals with intrinsically hazardous work like we do has adopted the simulation strategy articulated, the crisis resource management, and they don't have level 1A evidence. Okay. So in summary, medicine is very complex. It's effective, but it's dangerous. You really need a framework to work on these behavioral skills. You want to have the ability to prevent these errors, improve teamwork, and it's really essential to improving the safety of our practice. It's been proven effective in other complex, dangerous industries outside of medicine. And simulation on OB care can be used to not only improve the technical skills, but really focus you on those leadership, those communication skills that are so important. So I want to leave you with a final thought. This was a great quote from one of the passengers. It was a great landing. And talking to Pilot Sullenberger, he's visited a variety of institutions around California, he swears that it is his crew resource management that allowed him to do what he did on the Hudson that day. Thanks.